And thanks for joining me. How are you doing?
Hi, I'm doing great. I just actually finished recording a couple of the online content pieces for my breastfeeding course, so that was fun.
Oh, awesome. Can you
Yeah.
share? Is it too fast? Yeah.
No, I went through, I talked about billing and reimbursement for one section, and then I recorded my favorite section, and sometimes I go back and forth on whether to have it recording or live, but how the birthing process can impact breastfeeding. And on how we can like decrease risk of orthopedic injury during birth. And I just love that topic. So I recorded that one, and then I need to next spend time recording one on supplemental feeding devices and milk storage and formula and all of that. That one takes me about 90 minutes, so I needed more time.
Okay, so let me ask you. So, with the birthing process, there was a case that I recently wrote about, and it was actually a physician I treated in the hospital who had a pretty extensive amount of hemorrhage that resulted in a hysterectomy and ICU stay and all of that. And her main goal was like in the ICU, I remember she wanted to just get to the point where she could tolerate being upright to hold her baby and start breastfeeding, like during her hospital stay. And that's not like unusual, right? But it's just that she was in such a state of, let's see if you can even sit on the edge of the bed. Let's see if you can actually stand up and your vital signs not drop. What is the impact of just birth and all the birth types and experiences on breastfeeding that you've encountered?
Yeah, there's so much. There's so much. One of the things I wanted to like really put out there for this talk, especially, is that there's so much information to breastfeeding, and it's way more than you would even imagine. So for somebody to know all of it is almost impossible, just like it's impossible to know everything about PT or rehab. But when you think about a mom who's hemorrhaged, had a hysterectomy, she's missed out on skin to skin time, right? And so that skin to skin time is really going to impact her baby bonding beyond just breastfeeding, like how she feels about her baby. And so she's going to miss out on that component of it, the oxytocin. That will delay also some of the different components with breastfeeding because oxytocin is part of the milk ejection reflex. Hemorrhage can lead to iron deficiencies and anemia, which can impact the pituitary gland, which also impacts all of those hormones too. So, yeah, and then you just think about epidural, all the different medications within that. If she went into labor on her own, there's hopefully she will have started that prolactin cascade. But yeah, there's just so many pieces, pain medications, how that can impact. Yeah. So and then you think about all of that. And then where is our role? And especially acute care PTs, I feel like they have a really unique role to use what we already know about getting mom to the edge of the bed and OTs too, like how we work within our rehab session. How do we promote that baby bonding? How do we promote improving oxytocin? Like really promoting that skin to skin because that is what's going to help that mom connect more with her baby. Yeah, so we have to understand the underlying physiology of it in order to understand our patient education pieces. They can really impact how not only how like moms feel about their babies, but how they're able to promote their milk production. And also I always like to think about the number one killer of moms is suicide. And so if we can help her meet some of her breastfeeding goals and make her feel comfortable while breastfeeding, like it shouldn't hurt, then maybe we will have impacted that number. And I feel like that's a huge responsibility that we have to look at, like how can we help decrease that number and how can we help women feel supported. Yeah, sorry, that was a long answer to your question.
It's
There's
not a
a
long
lot in there.
No, it's not a long answer at all. Like our lactation consultants, we didn't have a lot of them in the hospital. And so when they understood what we were doing as OTs and PTs, they actually embraced the fact that we were helping out, especially with those moms after cesarean hysterectomy who had their uterus removed at the time of their birth, after a really complicated long cesarean section. And they were really just happy because the breastfeeding attrition rates, the amount of times that they could get a mom to continue trying to breastfeed and just doing all the things that they needed to do for the colostrum to come in and all of that was really affected by pain. And that was really infected by like the position their incision was in. So when they realized that we were actually helping those moms and helping them, they embrace that. But we've encountered some hospitals where lactation consultants are like, hey, you're stepping on our toes, you're stepping in our area, you're practicing out of your scope. So, how do you actually differentiate what you're doing as a rehab therapist with someone like a lactation consultant who's, at least that's their training to do all those things to help that person start breastfeeding if that's their goal?
I think this is a good question because when I went through my CLC training, which is the Certified Lactation Counselor training, I was so impressed by how open the lactation community is to having more people because we want more women to meet their breastfeeding goals. So they really push towards having more people understand this knowledge. Like I took that course. It was a week-long course, and I did it with a scholarship. I didn't have to pay really for it. So that's like huge. Like they just gave me money to learn this. And anybody can go out there and find the scholarships for it because there's just a lot of promotion of education, which is why one of the reasons why I linked into starting this course specifically for birth professionals, rehab professionals, because I agree a little bit with the lactation consultants when we come in and we're making these modifications on position. We're doing it well intentioned, and we have a mom is having incisional pain and we need to modify baby's position maybe so that baby's not pushing on the incision. But what we don't maybe realize is that we're impacting potentially the milk transfer when we do that. And so what we need to be skilled at is looking at that milk transfer or the infant latch and make sure when we make these positional changes that we're not negatively impacting that. So I think that the lactation professionals who are a bit adverse to our modifications is because they know like how important that the first 2 weeks are the most important for helping moms to meet their breastfeeding goals. That's when most breastfeeding cessation is. If we can show to those lactation professionals that we're making these modifications and we're aware of the infant latch and making sure there's still good milk transfer, I think we'll get a little bit more respect from them. But before I took this class, when I became a CLC, I was making all of these changes, biomechanical changes to the mom on how she was breastfeeding based on her orthopedic complaints without actually considering that infant latch component. And man, I just wish I wouldn't have done that sometimes because I could have negatively been impacting it and not even realizing it. I just didn't know any better. And now that I know better, I just do better.
Yeah.
To
Here's the
Maya
thing.
Angelou, right?
Exactly. No, and I caught that too. And thank you so much. A few people know this, Anne, is that I had an opportunity to work with you last summer. And working with you and actually doing the home postpartum visits within the first like week, like you have to realize I've never done that under a hospital system. I did that on my own when I started a mobile practice, and I would see moms and actually do visits in the hospital when they were still in the hospital after a C-section or a vaginal delivery. I was also a doula. But when I actually worked with you at Heart of the Rockies Regional Medical Center, I had no idea how a hospital would support me going out as an outpatient therapist and doing a postpartum home visit. That was like bonkers to me. First of all, coolest thing ever. But then, second of all, we had been teaching in the EVRAD course, Enhanced Recovery After Delivery, to acute care OTs and PTs. We had been teaching rather a breastfeeding component and talking about positioning. And year after year, since we've been teaching this content since 2021, our lowest survey scores are on the areas of breastfeeding. Therapists finish our course and they do not feel comfortable still about breastfeeding. And when I started to do the postpartum home visits with you in the summer of 2024, I didn't feel comfortable. I thought I had more confidence the more I was doing it. And then I realized I actually don't know what I'm doing. I don't know if I'm actually negatively impacting the infant latch. I don't know all of these things. And so your course to me, like in April, like I will be there. I will definitely be there. I'm excited for it because I need to learn what I don't know. You don't know what you don't know, but you don't also want to cause harm. So what do you think in terms of the acute care therapists who are starting to treat more? in the hospital or us as mobile practice OTs and PTs who are doing home visits or even telehealth, what do you think that we are doing that could actually be harmful in terms of the lactation goals that parents are having?
Yeah, I think the biggest piece, there's two pieces. There's the misinformation component. There's that because a lot of breastfeeding, of our initial understanding of it is really based off of bottle fed culture and not breastfeeding culture. Because not that long ago, like I'm a baby from the 80s, about half of those children were breastfed, the other half were bottle fed formula. And then before that, like my parents' generation, formula was seen as superior, so they didn't breastfeed. So we're, to give ourselves grace, we're functioning off of knowledge the best that we can, pulling from more of a bottle fed culture. So there's that component to it. So there's a lot of misinformation around that, like timed feeds, sleeping through the night, how much milk a baby ingests, how can we tell if they're getting enough milk, all of those things. So once as rehab professionals, we understand mastitis is a huge one too, by the way. But after we understand all of those, the actual physiology of breastfeeding and how it works, we can do such a better job educating moms just in the moment, right? Every mom is gonna say, "Oh, I don't make enough milk." We all say that. I've breastfed three babies, and on my third baby, I was like, I don't make enough milk. And we just feel it because you can't see it. You don't know how much they're taking in just by looking. So we're all going to have this like self doubt. And if there's somebody in your corner being like, no, we can tell that your baby is actually getting enough milk because of this and this, then we can just help that mom meet her breastfeeding goals. So there's that misinformation component. The second part is this unknowingly altering the mechanics of milk transfer. And that is with our positional recommendations based off of orthopedic injury or complaint, right? So mom has neck pain. So we're trying to like change how, maybe we're going to offer a side lying position. If we offer a side lying position to a baby that's like less than 2 weeks old, that's actually a really hard position for a baby to learn to latch in, which is unfortunate because for the mom at that time, it's a really great position. So we have to teach that skill. It's a skill to be taught for the baby on how do we latch in that position? How do we optimize that position to best meet their needs? And then how can we teach mom to help baby latch in that position if that's a position we're going to offer? We can't just say, oh, let's try sidelining, here's some pillows, and then you're good. No, we might have to have mom latch the baby in a sitting position. And then once baby's latched, have her lay on her side. It's like once baby's latched, you can change the position. And then if baby pops off, then you'll know that maybe they didn't have an efficient suck in that position, or maybe baby has some like cervical tightness that needs to be addressed. Maybe they have torticollis. There's just lots of things to really consider about what would impact that milk transfer that I just didn't ever think about before I learned this. And I also really like calling it milk transfer as opposed to always just latch because you can look at a latch and you can say, oh, that's perfect. And then the baby's not transferring the right amount of milk. No, it's actually not perfect. It doesn't, we might think that the latch looks great, which is an important skill to have, an assessment of the latch. But we also need a skill of breast assessment. We have to know how to assess the breast, assess the latch, and then assess the milk transfer component, which is reliant on the first two. So if you don't know if what you're looking at with latch or breast assessment, then it's really hard to know if that milk transfer is efficient or not.
I You're describing my practice. I cannot tell you at this point how many moms I would put on their side because of a tailbone injury or because
Mm.
it was so painful after a third or fourth degree tear to just be in that sitting position. And I would just say, you could just breastfeed on your side.
Yeah.
And I'm like, you're calling me out, and for good reasons. It's hard to be transparently wrong when you're a therapist and you're just doing the thing, but you're blind to if it's actually now causing a disruption in that milk transfer, right, to the newborn. And so we do. I admittedly have been teaching this course, I don't know, to how many therapists now who are probably doing this in their practice. And this is where I'm like, okay, now that we know, we do better. Now that we know, we get more education on this very specific skill that all these other interventions, we can even say, I'm not doing anything lactation wise. If you're changing a mom's position, first of all, if you're changing a mom's position because you found it's better on her cesarean incision, it's better on her tailbone pain or their tailbone pain or perennial laceration, and you're treating them in the hospital or in the home, then in changing their position, you're changing the activities that they're able to do in those positions, which a lot of it, how much percentage of time is spent with breastfeeding if that's their goal? How much time? Do you know? And like how many hours a
Well,
day, like moms are breastfeeding, how many hours a day are they engaged in that activity? Do we have an estimate of that?
I know, right? I One of my favorite memes is this lady at the doctor with her baby, and the doctor says, "So how often does your baby breastfeed?" And she just says, "I don't know. It's just boobs. Boobs all the time. It's just boobs." And the doctor's, "I've never heard a description." And she's so accurate. And he's, yeah, so accurate. It's just a lot of time. It's like boobs all the
A
time.
third of the day, I think, right?
Yeah, it's
Third
like,
of
well,
the
it's what kind of baby do you have? Because I have a baby that snacks. What if you have a snacker? And then, like, my baby that was a snacker, he's still a snacker, by the way. So he snacks all the time. But man, he was driving me crazy because it was like every hour and a half. And that had nothing to do with milk transfer. That kid was just a snacker. So, like, baby temperament also changes how they're going to find comfort and nourishment and liquid, like all of those things. So yeah, a
Wow.
lot of time.
Okay. We have one question
Yeah.
from the audience. Does preeclampsia affect milk production? It's a good one.
Oh, that is a good question. I don't think that preeclampsia in and of itself as a disease pathology affects it. I could be wrong. It is not something that I remember going through in pathologies of the mom that affect the infant. Now, indirectly, for sure, because those moms are more likely to be induced if it's pregnancy preeclampsia. And then postpartum preeclampsia, then you're looking at like a hospital stay. So time more than likely not as much baby bonding time and skin to skin.
Wow. So indirectly, definitely can affect just the opportunity, but it doesn't, like hypertensive disorders in general are not affecting the body's ability to produce milk.
Yeah, I do not think so. Now, like PCOS, diabetes, those do.
How does diabetes?
I know it's because of the hormonal component. That is one that we go through our class, and like at the very moment, I'm not remembering, but it's a hormonal piece that affects it.
Wow.
And then part of it is, if this is interesting to me, if the mom, so if when my mom was pregnant with me and she had diabetes, I didn't form glandular tissue potentially in the way that I should have, because diabetes affected that growth for me as an infant or as a baby in the womb. And then when I go to have a baby, I have a hard time with milk production because I didn't have enough glandular tissue that formed when I was in my mom's uterus. So you look at some of the disparities of health in some of those communities where there's more diabetes, that piece will affect multiple generations, right?
Oh my gosh, what? You just blew my mind. I'm thinking, and just in terms of, we talk so much about just determinants of health and things like that, but that genetic component, my gosh,
Yeah.
the genetic component of the health of the mom can affect the grandchild.
Just because then the mom won't have, may not have the same amount of glandular tissue, so she may not be able to exclusively breastfeed just because
Amazing.
of that formation. I know. So,
Yeah. I have a question, and it's from, we recently went to a combined sections meeting, CSM, with the American Physical Therapy Association. And my residency, where I went to a women's health physical therapy residency at Duke, their hospital presented on an 18-month pilot program where they offered acute care physical therapy on the maternity unit. And they were giving all of these stats. And just sharing some like jaw-dropping like figures. They had researched like what the average readmission rates, maybe about 7 a month before they piloted their program. And during the whole course of their 18-month program, they saw a total of 6 readmissions, right? So it resulted in a cost of $500,000 of savings, all of this. But one of the things that they were talking about were that the readmissions that they had received, some of them were cases of postpartum hemorrhage. And that could have been retained placenta, things like that. And they were talking about how they don't know that physical therapy or just rehab services in general could impact someone who may be at risk for postpartum hemorrhage. And so, a question for you is just on the education level for the rehab professional, for the birth professional who wants to learn more about how to improve, or strategies to improve breastfeeding in this patient population within the first 6 weeks after birth. Is there any kind of correlation with hemorrhage or retained placenta or just anything like that you could actually be more mindful of or more aware of for patients at risk for that?
Yeah. So don't let me forget to come back to the hemorrhage. So I want to talk about the placenta, the retained placenta first, because I have caught this a couple of times. So, what starts the transition from colostrum to mature milk is complete delivery of the placenta, complete delivery. So, if there's not a complete delivery of the placenta and you have retained placenta, that milk transfer won't happen. It'll stay like that colostrum because the body still thinks that the baby's there because the placenta is still there and the hormones from the placenta are still coming out. So one of the ways to get check and make sure we don't have a retained placenta before it comes down to this like infection route is if their milk isn't coming in. And so this happened where this mom, she had a vaginal birth with no epidural, so there wasn't a reason for any delay in her milk coming in. And it was just a couple of days behind. And we looked at it. I had her express some out into a cup and it just looked like colostrum. And I'm like, you have retained placenta. That's why your milk isn't coming in. And so I contacted her doctor. I have a good relationship with doctors, which I think is really important in order to effectively communicate this. But I contacted her doctor, had her come in, and they checked, and she did have a retained placenta. So we were able to so they did an extraction and BNC, and so then her milk was able to come in. And that was the only thing that she had noticed at that time, but it would have for sure progressed to something worse.
Infection, all of it, sepsis. I
All
mean,
of
we've
it.
seen, yeah, postpartum
Yeah.
hemorrhage. You said that you wanted to go back to that, but the sign that you knew, telltale of retained placenta was the fact that there was no milk transfer or that her milk hadn't come in. So
Mm-hmm.
milk production was a direct, retained placenta rather directly impacts milk production.
Mm-hmm.
Wow. And there's just before we go to postpartum hemorrhage and round out this conversation, one of our audience members, Dr. Catherine Sylvester, so she's dropping where we're going live on Facebook. So you might not be able to see this, Anne, but she dropped a free radiation biology med. I believe that is the journal, but preeclampsia affects oxidant status and anti-inflammatory potential of breast milk. So I think what she was dropping there is preeclampsia and its impact on human milk activin A concentration. And that's from the journal Nutrients 2023. So thank you, Dr. Sylvester, for that resource. I think honestly, where this rounds out this conversation with us, and is that by increasing our education on breastfeeding, on lactation, and on things that we would do in the hospital as rehab therapists or birth providers or doulas or anything that impacts the position of the mom, the activities of the mom, is going to impact their number one occupation. If that occupation is breastfeeding, everything that we're doing from a rehab standpoint, from a medical standpoint, anything that's impacting activities and position impacts the activities that they are engaged in, which is breastfeeding. And we should have really a clear understanding from our standpoint of what breastfeeding is, anatomy wise, physiology, biomechanics, because that's such a huge occupation that moms are engaged in within the first however long they're engaged in it, right? And if we're doing anything really early on, we should know what their occupation entails. That to me is just common sense. And I really can't believe I've been practicing so long and not really have taken a dedicated breastfeeding course in terms of the mechanics, in terms of the musculoskeletal impact, all of it up until this point. And so I do want to just let people know April 5th and 6th, Anne Croghan is teaching in person live. There is a hybrid component to this course. It's all open to birth professionals, to rehab professionals. It'll be in Loveland, Colorado. And anything that you want to talk about with that course that you want people to know what to expect. And then please finish your thought on postpartum hemorrhage if you can, since that's such a huge area of impact. But anything about the course.
Yeah, this course is my favorite to teach because I feel like to me the information is so like basic but also mind-blowing because we just don't learn it anywhere else. And it really should be more in depth and a part of our training when we're working with this population. Because our number one goal is to help mom meet whatever their breastfeeding goals are. But so I love teaching this class because of all the new things that people get the opportunity to learn. I always learn something new. I love manual therapy, so my favorite part is to go through all the different manual therapy components of mastitis because everybody seems to think that we just use ultrasound for mastitis. And while it's a recommended tool, I just feel like we can do so much better. That we spend a lot of time actually doing manual treatments, especially really focusing on the upper quarter, which sometimes if you're a pelvic PT, you've forgotten a little bit about. So it's good to have that review. And then some of my different techniques that I use. And we incorporate many different manual techniques, including some of the lymphatic drainage pieces. And
Which excites me. I'm a lymphedema therapist,
I
so
know, right?
yeah.
Yeah, and really important too for acute care therapists to understand to help with that engorgement initially and for patient education for later on when they are discharged. But yeah, I love this course and I'm so excited to be teaching it again. Yeah, oh, so hemorrhage, real quick. Because hemorrhage affects it can affect iron. It affects how the pituitary gland and our hormone formation and our breastfeeding hormones come from the pituitary gland. We could have not a great milk supply if our iron levels are low. For hemorrhage, it's just really important that those women are on an iron supplement that they can readily absorb and not some like knockoff iron supplement brand that isn't well absorbed. And we go into that a lot. Actually, at the last course I was teaching for this lady, she was trying to figure out why she struggled so much with breastfeeding. And I also think the nice thing about this course is it does help you take a deep dive into maybe your breastfeeding journey and you can find a little bit of healing if it was a struggle, if that was a part of your story. And so she was trying to figure out why she didn't have a good supply. And she really felt like it was her fault as a mother that she didn't try hard enough. And when we started talking about the hemorrhage piece, that was an aha moment for her. And she said she'd been anemic ever since she hemorrhaged. And so that there it was, more than likely was why her supply was so low, is because she never took an iron supplement, even though she was anemic, because she wasn't. And that's something that as rehab professionals, we can catch. We can look at blood work and say, no, you're anemic. You should take something. Talk
Absolutely.
to
And,
your doctor about it.
anemia, it's hemorrhage, anemia is all relative. And so you're going to find that your medical system, your healthcare providers, they're looking at values and they're just pasting it on every single person as if they're just, these are the values and this is where our cutoff is when we intervene. And we've been very vocal about that. We're anti-standardization when it comes to the hemorrhage piece because it affects everybody so differently, even to the extent of how much adipose or fat tissue someone has. It affects you so much differently when you experience blood loss after delivery. So and I cannot wait this course, April 5th and 6th in Loveland, Colorado, but you're teaching elsewhere. That information is going to be posted and linked to your page of all the locations. Those locations are expanding as we're just finding more and more clinical sites that really want their therapists to just have the knowledge of breastfeeding strategies and education that can really help our patients really early between the first 0 to 6 weeks. We are not waiting 6 weeks to treat moms anymore. We're breaking that standard of care. I admit I went into enhanced recovery after delivery pretty blindly, changing positions, doing all this stuff, affecting latch. And I don't want to do that anymore. I will be in this course with Ann Croghan. I cannot wait. I want to learn at your feet. I want to see you in person. I want to learn all of these skills that you're going to teach us. And I can't wait to see you guys there. So join us April 5th and 6th for a course on improving breastfeeding strategies for this population. As birth professionals, it's open to doulas, it's open to OBGYNs, midwives, nurse practitioners, rehab therapists, OTs and PTs, acute care, home health,
Pediatric.
outpatient, pediatric. Oh my gosh, pediatric OTs and PTs. Please come to this course and learn all you can about the mechanics of helping our populations improve their goals. Thank you. Thank you so much, Anne.
Yeah, thank you all. Appreciate you, Rebecca.
Absolutely. See you all. Bye.
Bye.